Well, good morning, everyone. As the president-elect of the American Head and Neck Society, it's my pleasure and privilege to welcome you all back for the second day of this amazing meeting. I want to give a wholehearted thanks to the many people that made this meeting possible, and kind of the lead of the meeting, Jonathan Irish, Bob Ferris, the program chair, Eben Rosenthal, Sherry Ann Nathan, Bert O'Malley, who is involved in the fundraising, and all the people at BSC. The staff have really been incredible, and this team has really made this meeting possible with the input of the program committee and all the participants and all the people attending. So I think we're off to a great start. Yesterday, opening ceremonies, the scientific sessions, the proffered papers, the panels, they were all very, very good, and I think we have a lot to look forward to over the coming days, and particularly this morning with the president and his citations and lecture and keynotes and lots of other activities today. So one of the best jobs of the president-elect is getting to announce and introduce the president at the annual meeting. So this year it's my pleasure and privilege to introduce your AHNS president, Dennis Harry Krause. Can I get the slides? Great, thank you. Okay, well, Dr. Krause was born in Indianapolis but raised in Philadelphia. And then he went on to do his education, his undergraduate education, and his medical school at University of Rochester in Rochester, New York, and moved from there to the Cleveland Clinic. And we heard about his recognition of Dr. Tucker there yesterday, and that was made a big impact on his life. He did both his internship and his residency there, and was very successful, and then went on to a fellowship at Memorial Sloan Kettering. And he was there on the faculty for 21 years, and it's hard to imagine that institution without him. We still associate him for his leadership and great work that he did there. And but he went on to take another position still in New York, where he became the director of the New York Head and Neck Institute for Northwell Health. And with that, he's a professor of otolaryngology at Hofstra Northwell School of Medicine. And he has through all this time, had many achievements and many awards, and they're too numerous to mention, but I'll highlight a few. He was 2001 New York City Honorary Police Surgeon, and that was a meaningful year for that award. 2008, he was named an honorary lifetime member of the Israeli Society of Otolaryngology Head and Neck Surgery. Then in 2012, he was the guest of honor of the American Laryngologic Association. 2013, he won the honor award from the American Head and Neck Society, and for many years, dating back to 1998, he's been cited every year in the Best Doctors in America and the New York Magazine's Best Doctors, as well as the America's Top Cancer Doctors. So it's a long time on that list and very well deserved. So in terms of scholarly activity, if you look at his CV, his incredible accomplishments, he's written 225 articles in peer-reviewed journals, 47 book chapters, and kind of most remarkable, 584 lectures nationally and internationally. And I think you kind of think of Dennis and his, what a tremendous ambassador he is for our specialty. He's made a lot of friends around the world and traveled and brought his knowledge and expertise to many people in all the continents. And you know, I think in general, he's a good ambassador and a good friend to many. His particularly holds dear his friendships that he's maintained with his trainees, his colleagues, but also his coworkers, people that kind of work at the hospital at all levels and support the mission. And recently he came to MD Anderson to give the Helmuth Gepfert lecture, which was, you know, one of our great honors that we can bestow. And he, during his lecture, he singled out a woman that works in our operating room that had worked for many years at Memorial Sloan Kettering, and kind of called out to her during his formal presentation. Just kind of showed kind of his recognition of, you know, all the people that make it possible for us to take care of our patients. So I'll have the next slide, please. So while this kind of academic credibility and hard work and working at great institutions helps to get you involved in the American Head and Neck Society, I think what gets you to be president is a lot of hard work on behalf and service to the society. And this is a list of some of the important roles that Dennis has played in the society over many years. And it even predates the American Head and Neck Society. And while I won't belabor the point about the merger of two societies, before the American Head and Neck Society, there was the American Society for Head and Neck Surgery. And already at that time, shortly after completing his training, he was involved in these important roles in that organization. But within the American Head and Neck Society, there's service, and then there's real service and contribution that he made as the COSM secretary, and also I should have highlighted above that the secretary of this organization from 2007 to 2013. And that is a real role of service and sacrifice to the specialty that just takes every day lots of activity and communication with people around the world, and he did the remarkable job of that. And then he moved on to serve as vice president, president-elect, and now this year has done a wonderful job as president. And there's presidents and presidents, and this year is particularly intense job. And he, first of all, because we did COSM and now the head and neck meeting, it's 15 months instead of a year, which just adds to the service that needs to be done. But in addition, we had a retreat this year that led to a new strategic plan, and having to sort of shepherd us through that process and get it started was a tremendous amount, required a tremendous amount of initiative and energy and passion, and he did that all to the benefit of the society. So I think those of you who know Dr. Krause, that in addition to operating and traveling and doing all these things, that his real passions are his family. So here he is with his sons, who are here in the front row, and it's Cameron and Colin, and then his lovely daughter here, Devin, and his best friend and soulmate and life partner, his lovely wife, Daryl, who's here as well. And golf, we heard about from Jonathan Irish that was also a main passion. So here he is in a beautiful course with friends somewhere, and here he is a little closer to home. He's got the Statue of Liberty in his hand here. And his last one is rock and roll. So pretty much every time I would see him over the last 20 years, he'd say, Jeff, it was great. I took Cameron and Colin. We went to, to Coachella. Next, we're going to go to see the Allman Brothers Band at the Beacon Theater, where I had the pleasure of going to a concert with him. And then, of course, the last shows of the Grateful Dead. That was a big thing. And I think he particularly held dear this group, the band, he had a close friendship with Yvonne Helm, who recently passed away. And I know that through that, his interest in passion in rock and roll increased. So, this is the shining moment for the president, this particular time right now where he's going to give his lecture and citations and recognition, and the end of not the end of a lot of years of service, because he still has a couple more years as past president, but the many years of service. And I think you can see him here with his family at Mount Rushmore, and he's kind of looking up, and I think he might be thinking, well, what are we going to do to immortalize the AHNS presidents? I think maybe something like this, we'll have to work it out. But without further ado, I proudly present our president and look forward to his talk and his other remarks here. Thank you.
You quickly find out who your friends are, and obviously Jeff is one of them. Jeff, I'm blown away. Thank you. You've already heard the award winners. And again, they're too numerous to mention, but we are very proud of your accomplishments. You represent the future of this organization, and we wish you all the best luck. And all of us are here to be part of your future and your mentorship. Any way we can be of help to you, please reach out. As Jeff alluded to, the one thing I can't do is recognize each and every one of my fellows, both at Memorial and Lenox Hill, but they are a major part of my legacy. And it's that legacy that really led me to choose Harvey Tucker. To quote that other great physician, Dr. Dre, many of my honorees today are or paraphrase, they are the hoods I grew up with and the brothers I grew up with. And in many ways, Harvey has been like a second dad to me. Harvey and my father, ironically, interacted together almost 4 decades ago as my dad served as a career-long drug rep for Eli Lilly. I made some of my introductory comments about Harvey yesterday. I think the one thought I'd like to leave you with about Harvey was when Harvey's a very philosophical guy. He's the one who can speak a couple words of language in virtually every language in the world, some of which are languages that have been lost. But when he described himself, he would use the Greek word iatros. And although it's a word that means physician, in its true essence, it means teacher. And that was the thing that he prided himself in the most. So Harvey, I know that you and Cindy have taken considerable efforts to be here. Cindy was always part of the Team Tucker, and at the time I was there, the Team Cleveland Clinic. And I'm just really grateful and gratified that you would be my guest of honor. Please come up. Each of these individuals, and you have an opportunity to read their biographies, but I could wax on eloquently for each of them for 5 or 10 minutes and have no time for my lecture. The next person is the Distinguished Service Award, and to me there's an element of irony here, because although Ehab is one of my greatest friends, there was really no choice about who got this Distinguished Service Award. So this was really an intersection. And, time doesn't allow it, but to me, this is the great American success story. So although this is an international meeting and we applaud all things international, Ehab's someone who came here from a foreign country. He assimilated, he thrived, and he ultimately excelled. His service to the society has been par excellence, as he served 6 years as treasurer. He and our paths seem to have been intertwined both through the AHNS and through the North American Skull-Based Society. And his service to the society has been just exemplary over the last 6 years. And I know that he will continue on as a phenomenal leader as he joins the presidential rota. This year's Distinguished Service Award, Ehab Hanna. So my presidential citations I've actually done in the order in which I met people. So I met Mike Benniger literally my first day as an intern in 1985 at the Cleveland Clinic. The pathway is very similar to what I described with Ehab. The amazing thing about Mike is that even though Mike was a contemporary, he's been an amazing mentor. He's someone who's pushed me on a national and international agenda. He's been a tremendous boost to my career. He's someone that I've been able to look to for advice. It was certainly a privilege for me when he asked me to be his honoree at the American Laryngologic Association meeting 4 years hence in San Diego. And again, as Jeff alluded to, the most important thing to us is family. And Mike and Kathy have been part of our family forever. They've been at all, they were at our wedding, they've been at all my kids' events, and just a dear friend. So Mike, please come up. My next honoree is Pierre Lavertu. Again, Mike was my senior resident. I was the junior, and Pierre, after a fellowship at the Cleveland Clinic, had returned to Montreal, and Dr. Tucker had recruited him back to the staff at Memorial. I'm sorry, it's hard to keep track of all these institutions. At the Cleveland Clinic, he spent a long career there and went on to join the faculty at University Hospital at Case Western. Pierre is the consummate surgeon. He's the surgeon who remembers every detail about his patient. The level of compassion and concern is unbelievable. And yet again, has been someone who has, over the years, always been part of our family and our family's events, and included us in his family's events. Pierre is a dedicated teacher, superior surgeon, and I'm happy to say my friend. Pierre? My next honoree is Greg Weinstein, and Greg and I met under somewhat awkward circumstances when we were both fellows, and again had a couple of years where we didn't really get to know each other. And again, as would be irony, my dad was calling on the department at the University of Pennsylvania, met Greg through his senior partner, Rick Hayden. And my dad kind of approached both of us and said, I think the two of you need to grow up and become friends because you have so much in common and you're great guys. The subsequent 20-year friendship has been legendary. But part of my recognition is for what Greg has done for our field. And clearly this was a joint effort between Greg and his partner, Bert O'Malley. Not only did they develop robotic surgery as it currently exists in head and neck surgery, but then they became mentors and they became teachers. And there's so many people around this room as I look around who have been to Penn, they've trained with him. You know, you can call Greg in the middle of the case, ask him for advice. If he's in the middle of his own case, he'll say to you, are you in bad bleeding or can I call you back in 5 minutes? And it's again, this combination of both service and friendship that that led me to ask Greg to be the recipient of one of my awards. Greg, please come up. So under similar circumstances, I met Drew Ridge. And again, Drew was part of the Memorial family. As I told at dinner the other night, I think my first head and neck case was actually a referral from Drew's wife, Aline, who was at the time was on the faculty at Memorial, and she called me up one day and asked me if I would see a patient with a parotid tumor. This has been, again, another one of these 25, 30-year friendships. Drew preceded me as secretary of the society. He taught me how to be a good secretary. I had the privilege of serving under him as when he was president. And it's just been a remarkable run of a friendship that again, was kind of just circumstantial. For those of you who don't know, Drew is internationally ranked in the senior level in fencing. And just has been a dear friend. So Drew, please come up. Next honoree is David Terris. David was actually someone we kind of walked by each other when I was interviewing for a fellowship at Stanford and nodded at each other. And it was years later, it's just going to shock you, but we were actually playing golf with Tim McCullough and Harry Hoffman in New Orleans at one of the national meetings. And I had a friend who was a member at Augusta National, and I would come down and visit him. He lived in Aiken, and David said, well, when you're down, just come on over and we'll have you over as a visiting professor. And again, the great thing about having wonderful friends is that your friends become your friends' friends. And my friend who was a member at Augusta one day said to me that one of the guys couldn't play golf, invited Dave, they hit it off, they became fast friends. Dave and I have had an opportunity to travel all over the country and all over the world, exploring our passion in golf. But the other aspect of it is that when I was at Augusta and Dave was chair, I always felt like that was my home away from home. And I would walk in, and the secretarial staff, the OR staff would all greet me. And I just felt like that was my second home outside of New York. So Dave, please come up. I know these are a lot of awards, but these are people who are important to me. John Coleman is not able to attend today. I applaud that. It's his 50th wedding anniversary, and he and his wife are taking a 50-year trip. Again, some tremendous supporter. John asked me to be the program chair for the combined research clinical meeting in Chicago. He subsequently nominated me for secretary. Again, had the privilege of working with his daughter Maria at Memorial, where she was one of our data managers. And there is little doubt that if it were not for John Coleman, I would not be standing up here today. Next person will fit in with the theme of my talk, and that's Nancy Leupold. Nancy was the founder of Spunk. This is probably one of the great patient-to-patient help group across the United States. There are 130 chapters. These patients encourage each other. Often they interact before treatment and then continue to interact after treatment. Nancy and her subsequent successor, Marianne Caputo, have changed the landscape of what patient care in head and neck oncology looks like, patient support. Nancy, this is their 25th anniversary, and it's a tremendous honor for us to have her here today. I should note that's her second Distinguished Honor Award, the previous one being from Keith Heller. My next honoree is Doug Frank, and again, Doug was not able to attend today, and again, for the right reason. His son had taken ill, unfortunately was hospitalized last week, and has gone on to a quick and uneventful recovery. But Doug has been my partner in crime through the Northwell system. He's the co-chief of the head and neck oncology program as we stretch across a 20-plus hospital system across the lower reaches of New York. He's been a tremendous educator, researcher, and he's provided me with incredible support and insights as I learn this new system, and helps me to navigate and be successful. So again, I'm sorry Doug couldn't be here today, but I certainly want to recognize his contribution. My last group of honorees are what we euphemistically call the four Mrs. Krauses. And outside of my lovely wife, Daryl, these are the four women who run my life. So Evangeline Garcon is my administrative assistant. She basically runs my existence from day to day. If you ever want to do something with me, you've been CC'd on a note to her. She runs my busy lecture schedule, my travel schedule, and without her, I don't know what I would do. My second Mrs. Krause is Maridalia De La Cruz. Maridalia started initially as my medical assistant. When my patient coordinator had moved on, we just made the obvious decision to have her become the patient coordinator, and she does an unbelievable job of juggling both the clinical and OR schedule. The thing that's most incredible about her is that I've never seen anyone shed more tears on behalf of my patients than her. My patients have her cell phone number, her email address, and they interact with her on a constant basis. She provides the compassion that I would hope that all my patients receive. Yvonne Estepa has been part of my maturation process over 2 institutions. She was an integral part of us employing robotics as well as a number of my other surgical learning curves. She continues to work with me 2 days a week at Lenox Hill as my OR coordinator, and she is really the person that I give credit for in the OR for having soothed the savage beasts. Lastly, my nurse, Denisova, who is unable to be here today, is my nurse practitioner. She just does an unbelievable job of overseeing patient care, coordinating care, educating patients, and unfortunately remains home at the shop to watch after things while we're all out of town today. Ladies, please come up. My slides, please. Thank you. So before I move on to my talk, I just want to say a couple words about the AHNS, and I think I've already expressed how proud and humbled I am to serve in this role. For the last 12 years, I've been part of the executive group. I spent 3 years as a counselor at large. I was 6 years as secretary, and then 3 years as president. I have served under 8 of the most amazing presidents, and it's been a privilege to learn and be mentored by each and every one of you. And I truly want to thank each of you for that opportunity. I think the future of AHNS is really bright. We have a tremendous leadership rota that lines up behind me, and I know that the society will be in great hands and will continue on for many years. The last thing that I would like to say to the membership is that it has been a very active year, and I do not think this is a stagnant society. We're a society that is diversified. We have changed the way that we do business. We had a retreat this year with 2 industrial consultants who have really helped us change the way that we do business and be forward-thinking. And again, I think you're going to see changes. They won't be smooth. At times they'll appear a little bit awkward. But I think at the end of the day, when you look at the fact that we recently created for the first time an endocrine section that will be led by Dave Terris and Maisie Shindo, I think you see a society that really is poised to capture the future. So my presidential talk today is Thoughts on a Patient-Centric Universe. I have no financial disclosures. So, and there's a tremendous amount of overlap with some of the comments that Ashok made yesterday morning. As you take the proverbial gavel from your predecessor, Doug Girard, you hear the clock start to click. And the clock is clicking towards this precise moment. It's a lot like Roger Goodell, and it's during the NFL draft, and Roger Goodell says the Oakland Raiders are now on the clock. And so you have a couple of potential opportunities. One is that you go on to draft Charles Woodson. Charles Woodson, from my daughter's beloved University of Michigan, went on to win the Heisman Trophy. He was an All-Pro, and recently was accepted to the Hall of Fame. Conversely, you could draft Jamarcus Russell, one of the great flops in the history of the NFL, with the first pick. As the ledger gets balanced today, I hope I fall in the former category. I thought about my topic for a great deal, and I reached out to some of our former leaders and speakers, and you can see this is a challenging group to try to match. Jay Shah's talk on the making of a head and neck surgeon. Again, ironic that Ashok talked about Chris O'Brien's Hayes-Martin lectureship on metastatic disease to the parotid gland. And again, for those of us who were in the audience that day, we all miss Chris. And it wasn't just the content of his knowledge, but it was the humor and the humility. And that was what was so special about Chris. Drew Ridges, we show pictures, they show curves. Drew, I will show no surgical pictures today. Carol Bradford's talk on head and neck cancer as a team sport. And last year, both my subsequent successor in 2 years, John Irish, and my predecessor, Doug Girard, giving this compelling contrast in healthcare delivery in the US and Canada. So I continued to ponder my topic. And ultimately, I went back to my roots. And as Jeff alluded to, I'm a graduate of the University of Rochester, both the undergraduate BA and MD program. It was a combined degree program that was funded by the Commonwealth Foundation. And what was so unique about Rochester, a place that takes its motto as Meloria, better, is the origin of the medical school. A young man named Abner Flexner from Johns Hopkins University wrote the Flexner Report, and he was presented to George Eastman, the CEO of Eastman Kodak, and based on this single report, George Eastman elected to fund the University of Rochester Medical Center and Medical School. The medical school was famous, or at least we thought so, for the adoption of the biopsychosocial model, something that was very common both in Vienna and throughout German medical centers. And it was that imprint that I think was left with many of those of us who came from Rochester. And I know there are a number of you in the room today. I've overlapped with a number of you, including Neil Futran, our local organizer for the meeting. And I think it's really that imprint that impacted upon this decision to talk about a patient-centered universe. So again, this is my effort to try to characterize the vastness of the universe. We don't often get a chance to actually look up at the stars and for a second of clarity think about that. But as our patients are faced with this diagnosis of cancer, this consumes their entire world. And without being cliche, it is this existential angst over their own mortality and their own existence that we need to try to exist. And again, the profession has come a long way. The willingness to solely cure your patient and not address their soul, I think, is long past. And that's what I hope to spend in my next 21 minutes and 49 seconds. So you'll see that I have a series of dichotomies and vignettes. They're often in pairs. And so I'm going to start with patient number 1. And these are patients that I recently treated. This is a 54-year-old Hispanic female. She presents with a T4N0 base of tongue cancer invading her larynx. She has quote-unquote long-standing asthma, a failure to diagnose. She had an emergent tracheostomy by my fellow. Eventually, after multimodality consultation, the recommended and desired treatment was resection of her base of tongue, laryngectomy, bilateral neck dissections, and a pec flap. She had postoperative radiation with chronic pain. My observations, again, are a failure to diagnose, large volume disease, limited social support, chronic tobacco, alcohol, and drug use, and somewhat limited access to health care, or at least good health care. My second patient is a 72-year-old white male, also presents with stage 4 oral cavity cancer. Again, after multimodality consultation, he underwent angled segmental mandibulectomy, total glossectomy, bilateral neck dissection, tracheostomy, and free flap, with postoperative chemoradiation. He has suffered multiple episodes of aspiration pneumonia. Again, my observations, this patient had limited social interactions with depression. He had long ignored disease. He had relatively indolent disease. He had chronic tobacco and alcohol use. But most importantly, in contrast to my other patient, he had a doting wife. And you can see these comparisons, which I've already made, outlining the two patients. And so the question is as we interact with a patient, what type of interaction, what type of feedback are we going to receive from this patient population? Well, this is patient one's response, my first patient, the Hispanic woman. Dr. Kraus, you are so full of something. Thank you for no help. It's easy to be titillated, to have gallow humor, to try to think of something funny to say, but there's an element of failure in this part, on our part, to appropriately connect with this patient and give her the support and the need that she requires. Obviously, we can't undo someone's entire life. This patient had very little social support. Usually, she was accompanied to her visits not by a family member, but by her social worker. And again, it represents a failure. Contrast that with this, the much more desired response. And this came from the second patient. This was a gift. This hangs on my wall. Start by doing, wow, I can't read that far. What is necessary, then do what is possible. And so suddenly you are doing what is impossible. And that's St. Francis of Assisi. And again, I don't think you can have a more divergent outcome in two patients, each of whom were treated within the last year. So patient perception involves the care they receive, the outcome, the interaction they have with the physician and the entire healthcare team, the empathy they receive, and ultimately the component that we can't change is the patient worldview. And that is the one thing that I must say I've become sanguine about. You work and you live in New York, patients receive multiple opinions, sometimes they stay with you, sometimes they move on to other centers, and you wish them well and hope that that'll provide them with the optimal care that they deserve. So as we look at the patient, these are each factors that play a role in their perception of their world. Again, as a junior faculty member at Memorial, I would remember recommending what I thought was the best treatment for that patient, and they would either turn me down or go get some other care. In addition to the patient, there is the physician. And although I will state that ultimately I don't think it is about us, it is the multiple challenges that we undertake every day in trying to balance our own personal and professional role that play a huge role in how we manage and take care of patients. And I'll have some additional comments about this towards the end of my talk. So again, I want to go through three quick vignettes about decision-making from a patient perspective. And I'm going to talk about oropharynx cancer, larynx cancer, and thyroid cancer. So if we look at the NCCN guidelines for advanced stage oropharynx cancer, we see a multitude of choices. And again, I'm not going to go through each one of them, but when we talk about multimodality treatment, there are multimodality choices to be made. And one of my patients was a philosophy professor up at Columbia University, and as we went through each of these choices, he was truly pondering it. And again, these are the decision-making process facing our patients: treatment choice, facility, practitioner, conflict between recommendations, sometimes within our own institution, proximity to home, whether you seek out expertise versus convenience, and ultimately family support. And I alluded to this philosophy professor, and his comment at this point was, nothing is true, all is permitted. So again, I think these are the challenges that face our patients. Larynx, in addition to the treatment choices, it's the toxicity in which they endure. And this was a tremendous study done by Falchuk and colleagues, serves patients receiving chemoradiation, in which the endpoint was comparing physician perception of complications versus patient impression of complications. And you will see for each of these 4 domains, pain, there was almost this near uniformity. And through treatment, as you go down the x-axis, you see both a perception among patients or among clinicians that showed more severe pain, and patients' perception of more severe pain in comparison to their treating physician, and similar outcomes for dysphagia, nausea, and vomiting. So even during the course of treatment, we often have challenges in characterizing the distress facing our patients. The next disease that I want to move on to is the VA laryngeal cancer. And as I alluded to, Greg Wolf was one of those individuals whom I had the pleasure of serving as a secretary. And the fact that we performed a prospective randomized study comparing surgery versus non-surgical management in the VA setting and showed no difference in survival with 2 out of 3 patients preserving a larynx is a testimony to Greg. But again, it has indelibly changed the horizon in which we treat patients. Again, this was a journal article that we reviewed in 1986, literally during my first journal review club at the Cleveland Clinic. I say I'm often haunted by this concept, by this article, in which a series of volunteers were asked, would you sacrifice some component of survival to be able to retain your larynx? The classic argument of quality of life versus duration of life that our patients battle with every day. And you can see ultimately 1 out of 5 patients said that they would give up some component of life. 1 out of 4 said that they would have surgical procedure, and if they failed, they would then have a salvage laryngectomy. And this is the data generated. And the only criticism that I have of this study is that we know that our patients are either cured or not cured in the first 2 years. And the thought that you're going to make trade-off at 20 years probably isn't a realistic characterization of our disease. In conclusion, they felt that a 30 to 45 minute allowed for depiction of attitudes on care and quality of life. 20% of patients would opt out for what at that time was unconventional therapy, and that somewhere to 15 to 30% of patients would give up some component of life expectancy to preserve their speech. There was a follow-up study done by Ali Lacoure in Paris, much larger cohort of ENT patients seen at a university practice. And again, interesting data. 13% of patients couldn't even tell you what their position was. And interestingly, increased age, employmency, and high school education, all metrics for individuals with advanced intelligence and more success in life, those were the patients who had more difficulty in telling you what their position was. In the previous study, up to 75 to 80% of patients were willing to accept a laryngectomy. Now it was the converse, 25%. 62% said they would accept organ preservation, even with the stipulation of reduction in duration of life. And obviously, this has far-reaching implications for our patients as we help them make decisions, not assign decisions for their care. And it's this approach to treatment and our patients' approach to their life that has unfortunately led to a decrease in survival. And again, I don't think we can make decisions on behalf of our patients, but I think we have an obligation to educate them. And it's interesting to note that as we advance, patients with T4 larynx cancer in this country are increasingly undergoing upfront total laryngectomy for the treatment of their advanced larynx cancer. The last topic I want to talk about is thyroid cancer. And as Louise Davies and her colleagues have pointed out, we currently live in an era of an epidemic of overdiagnosis of this disease. Many of our patients have the perception that this may, in fact, not be a true malignancy. We had the recent data by Nikiforov and colleagues in which they describe the revision for encapsulated follicular variant of papillary thyroid cancer, or it is now called NIFP, in essence, a cancer that many of our patients may have undergone total thyroidectomy with radioactive iodine for a non-invasive cancer. And again, I think it's our obligation to try to segregate which patients have aggressive disease and non-aggressive disease. Moreover, my former colleague and friend Mike Tuttle has been widely quoted in that great medical journal, the Wall Street Journal, about the fact that many patients with microcarcinomas do not need immediate treatment. Again, I applaud these efforts, but it's led to a conundrum. Many of our patients call us and ask, did I really need an operation? Do I have this NIFP variant for what increasingly is perceived as a benign disease? Well, is it truly a benign disease? This was a recent ASCO poster in which data from Italy showed that in a prospective matched pair analysis, patients treated for thyroid cancer had an increased risk of unemployment, decreased income, and many of them chose to shift to part-time work. A previous study done by Blau and colleagues looked at the incidence of bankruptcy using the SEER database in our host state of Washington State. And as you can see, there is a 9.3 per 1,000 person year increase in the incidence of bankruptcy. This hardly has the hallmark of benign disease to me. So again, I think these are the type of constant vignettes, struggles, change in knowledge that we need to help our patients make decisions. Ultimately, yes, the thyroid is at the center of the world. And today, I would point out we had the inaugural AHNS International Committee in which we are trying to do a better job to reach out to our international colleagues and be true world citizens and try to make an impact on the world as we interact with our colleagues. As I alluded to, Spunk has played a major role, 130 self-help groups across the United States. This is data that I am grateful to our incoming treasurer, Bevan Yu. Bevan took a year's worth of Spunk newsletters and read each essay with focus on patient expectations, concerns, and priorities, counting the themes and looking at them before and after treatment. In 12 essays, 8 described focus on survival. Shocking. One individual focused on playing golf again. Glad to report I've never had head and neck cancer, and I've never written one of these essays. And the other essays did not discuss pretreatment, period. So look at the expectations after treatment. And again, this is a potpourri of things that we deal with post-treatment for our patient population. I won't go through each of them separately. You see an incredible overlap with the University of Washington Quality of Life survey. There are 12 domains, and virtually every one of those domains were covered, with the exception of recurrence and ORN. And not surprisingly, Bevan was one of the developers of this with one of our past presidents, Ernie Waymuller. So again, it turns out that this quality of life measure was tremendously prescient and gives us insights into the challenges provided our patients. CancerCare.org is an independent, not-for-profit operation in the United States. They recently undertook a 3,000-patient survey looking at patients with diverse backgrounds and a number of different cancers, not only looking at the barriers to engagement in care, but many of the financial, emotional, and quality issues. These are the 6 domains that they addressed, and I've picked out a data point from each of those domains. As part of their conclusion, they say we have a high degree of confidence that the results reflect the experience, perceptions, and opinions of a significant proportion of the people across the U.S. who have been diagnosed with cancer. So those domains, the first, patients who understand their conversation with a member of their care team, pretty good, generally in the 70 to 90%, but that means that 10 to 30% of our patients do not understand their diagnosis and their subsequent treatment. Opinions about cancer treatment, again, pretty good. About 90%, and again, not just focusing on their physician interaction, but with their interaction with the entire healthcare team. So only about 10% are outliers. But look at their ability to take their cancer medication. It generally ranges about 50% right across the board. And again, we have to do better. Also part of survey 2, only 23% of respondents had access to a patient navigator, and yet 94% said they were instrumental. If you look at the new Commission on Cancer guidelines for approval as a cancer center, navigators are essential. If you don't have a navigator, you will not pass the survey. Distress raised by care team members, and again, there's a whole host of them. If you look at side effects, only addressed about 50% of patients. End-of-life concerns only addressed in about 20% of patients. Again, I can't go through each data point individually. This is at cancercare.org. I encourage each of you to take a look at it. It is an absolute treasure trove of data. The ability to afford care. Again, somewhere between 20 and 30% of patients said they had some difficulty in some component of paying their bills and understanding what those bills meant. Activities were reduced completely or a lot. And again, you see this tremendous gradient where while our patients are under their cancer care, they have to change their life, a compelling life change. 40% of patients lack things like a healthcare proxy, healthcare advocacy, a living will, last will and testament. And again, I can tell you during my 10-year tenure as chair of the ethics committee at Memorial, these were common problems that we dealt with on a day-to-day, end-of-life basis. And lastly, end-of-life concerns. We as surgeons are often on the front end of our patients' care. Many of the times, by the time they've reached a point of not being able to be cured, we are dealing with them in a peripheral fashion. But we need to make end-of-life care a central part of all care. It can't be an afterthought. It can't be a special unit. It needs to be something that is ingrained in every component of our practice and our patients' care. This is the patient pathway that I tried to create for patient number 2, the patient with the oral cavity cancer that we ultimately cured and who was gratified for the care he received. Even I did our best to try to create a map. We failed. But you look at this list and it's exhausting. And it led, and this is a recent, this was part of John Irish's presentation last year, focusing on Ontario. And these are the 9 provincial cancer centers. And I talked to John about it. And again, I think that you look at the care that they provide in Ontario, and it's outstanding. But what happens when you live in Thunder Bay? What happens when you live in these small provinces? You're faced with coming down to Thunder Bay, which is, as you can see, only about mid-province. We're hoping that you have a relative in the lower concentrated area. This is a tremendous ordeal. Many of you might ask, well, what do you know about this? You work in New York. All of your patients are in this massive metropolitan area. But again, many of you have been my guest at my golf club in the Sandhills of Nebraska. And this town has 491 people. They service the golf club. They've become part of the community. And during the last 3 years, I've helped shepherd the care of 2 of these patients as they have died from widely metastatic melanoma. One of whom literally came to me as I walked off the golf course, was heading to dinner, and had the worst ophthalmoplegia I'd ever seen. And the only advice that I could give her was to get in the car, drive to Omaha, and I would speak with my friends at the New University of Nebraska and arrange for emergent radiation the following day. So these are the challenges that our patients face on a daily basis. And Ellen Sonnet is the current Strategic and Alliance Officer for Cancer Care. She's a former colleague from Memorial, and she states clearly it takes a village to cope with cancer, and I think she's right. This is work done by Bill Lydiot, looking at the impact of depression It's amazing to see that if you're on an antidepressant, your long-term survival is better than if you're on a placebo. And this was, again, a double randomized placebo-controlled study. All of your data points show improved quality of life. These, again, two vignettes. John Stossel, a consumer reporter in New York, lung cancer, being treated at one of the other leading venerable New York City institutions. He states, customer service stinks, there's constant delays, unexplained tests, failure to communicate. I can never reach my doctor on their phone or their email. Cost, there's no barcoding, overregulation, indifferent staff, and patient representation and patient rights feels unnatural, feels like grafting wings on a pig. Contrast that with the words of one of our colleagues, and many of you know Ellen Friedman. Ellen was chief of pediatric otolaryngology at Baylor Hospital. She recently wrote A Piece of My Mind, which is truly one of my single favorite communications from physicians within JAMA. And she talks about being notified, and again, these are Ellen's own words, so I have not violated HIPAA. She talks about receiving an email for benign chronic colon disease. She asks, is this care or is this expediency? What are the implications for patient confidentiality, physician liability, and billing? Absence of information on the psychological impact or patient distress. What are the implications for professionalism, care, compassion, patient-physician relationship? And her take-home message was that we need to convert this situation from I've got mail to I've got a physician who actually cares. The last component that I want to address is the issue about burnout among physicians. And this has become increasingly evident. This was data from the Mayo Clinic. Similar study was done by Charlie Balch, surveying the Society of Surgical Oncology membership. The rate is profound. It's roughly 50%. We see the tendency towards invincibility in physicians, isolation, lack of support, lack of autonomy, all of our increasing frustration with bureaucracy, chronic fatigue, and depression. There's the risk of burnout, there's the risk of suicide. Last year in this country alone, there were more than 700 physician suicides. Unfortunately, a record that none of us are proud of. It does reflect an increase in suicide across the United States, but far out of proportion to other professions. We need to be part of the solution, those of us who are in leadership positions. The Mayo Clinic, they talk about choice, control of your practice, flexibility. Camaraderie is critical, collaboration and teamwork, and the desire for excellence, both ownership and with partnership with your team. One needs to create a plan for balance and wellness. Create your own best year plan. What's going to be your best year yet? Don't medicate, meditate. And again, I'm not one who meditates, but take a minute each day and think and give yourself an opportunity to breathe. Figure out a way to assimilate your daily stresses from work to home. Partnership with family, my wife and kids, my dad, and yes, I thank Carol Bradford for the fact that I have a professional coach. I was recently struck by the remarks by Sheryl Sandberg. And as many of you know, Sheryl is the CEO of Facebook, small little operation on the West Coast. She spoke at the University of California, Berkeley commencement about a month ago. And when she dealt with her own tragedy with the sudden death of her husband, Dave, not from cancer, but from a fatal cardiac arrhythmia, she quoted Martin Seligman, the psychologist, and she talked about the three P's: personalization, I'm at fault; pervasiveness, this will pervade my entire life. Nothing will ever be the same. And lastly, permanence. I will never improve. And this was literally on the 1-year anniversary of her husband's death. And what she talked about was finding gratitude and appreciation, and that's the key to resilience. And when she talked to her own psychologist, and she said nothing could be worse than this situation, her psychologist responded by saying, no, there is something that could be worse. Dave could have had that arrhythmia while he was driving down the street with your 2 children in the back of your car. And I think it puts a tremendous perspective. And again, I don't know Cheryl, we have some common friends, but I have tremendous respect. And if you have an opportunity, this is online, I encourage you to read it. And she wrote this down. She wrote down, take the opportunity at night, as you go to bed, to write 3 moments of joy as you go to sleep. And this will create, again, what you perceive as was the highlight of your day and what will be the favorable parts of your day tomorrow. Again, a theme that has been common. We've talked about technology, and we know technology is transforming the way we take care of patients. But ultimately, it's just not technology. It's the team approach. And again, Carol addressed this as part of her presidential address. This is the 2013 Institute of Medicine report on delivering high-quality cancer care. And it starts with the central tenet that an engaged patient are the center of the framework for delivery of high-quality care. The key components ultimately focus on a team of people providing care, and there's a lot of similarities to the report that I provided from cancercare.org. This is just a small treasure trove of letters and notes that I've collected from patients. Some of them are negative, but the vast majority are positive. And this is truly one of my treasured possessions. So I encourage you to collect these, occasionally reflect on them, take a look at them. Again, some of the greatest heartbreak were the children that I took care of at Memorial when we were unsuccessful in their care, but there's still incredibly compelling notes from their parents and families. In ending, you guys didn't know I was a softie. I said I wasn't going to do this. So this is my family. This is at my son's college graduation. In addition to my wife, my kids, my parents who always sacrificed for my sister and I, and lastly, one of my patients and his wife. And to me, this is what it's all about. So, in closing, I'm going to collect myself. Be kind and be compassionate to your patients. Help them to understand their disease. Assist them in making treatment choices. Return them to the best quality of life that you are able. This is truly your opportunity to be a hero, and that's what these patients are looking for us to do. Again, I can't thank you enough for the privilege of serving as president. I hope you've enjoyed this meeting. I am eternally grateful to my team of people, and you all know who you are. You're sitting in the first row, as well as our partners from BSE. I would be remiss if I didn't acknowledge my tremendous friendship and admiration for Christina Kassendorf, our executive director. And lastly, thank you.